So I'm here to give a patient perspective. Now, all of us here have been in one or more medical systems, most commonly the NHS. Now, I've got no medical background, and as I said, I'm here to provide a patient perspective. I've been involved in a voluntary role with NIHR research since 2018, and more recently, I was invited to join the imaging group as one of two patient representatives. My patient perspectives are just opinions, and they may well change in light of what others have to say today. So, overview of what I'm going to be talking about. What is patient public involvement, routine imaging data, PPIE issues, public trust, and then questions we'll take as a panel. So what is patient and public involvement? Well, a bit of PPIE history for those who don't know it. The NIHR was established in 2006. And if you look at some of the supporting papers, and I only glanced at them, I certainly haven't read them all, noted that patients and public must be involved in all stages of the research process. And if you want to get a grant from the NIHR to do something like a doctoral study, it advises you that PPIE is as important in your project methodology. You must demonstrate how you're working in partnership with the patients and population of project aims to help. And the important word here is population, because we'll come across that again, especially in AI, the importance of having a diverse data set. And I'll provide the link there to the NIHR website. So some examples from NIHR of public involvement. And personally, I think I've been involved in quite a few of these. Identifying research priorities. You can become a member of an advisory group for a research project, both before grant is actually given by the NIHR and once it's up and running. And you can be a co-applicant on a research project, and you can comment on patient information leaflets, both for medical charities or for your local hospital. And another important thing is trying to encourage members of the public to take part in research. And here in the UK, in May every year, there's something called National Clinical Trials Day, where you go around, you put on a T-shirt saying, I'm in research, and you stand in front of your hospital and everybody walks past you, and you say, wouldn't you like to get involved in research? And I think most people are embarrassed and they move on. So whilst it's obvious that patients are involved in trials, involvement in setting research priorities is probably slightly less well known. But patients do get involved in certain priorities, which is quite important, because you as a researcher might think, oh, this is something that really interests me, but it may not be of particular interest to a patient group. And I've been involved in a number of these related to my own health conditions, and these are run under the aegis of the James Lind Alliance. James Lind Alliance is funded by the NIHR, and it aims to identify the top priorities for future research. And I was given a long list of 78 unanswered questions, and I had to reduce them to a short list of 10 questions. And these were pooled with other patients, and eventually you got the 10 top patient priorities for research. And by the way, the man on the right is James Lind. He was a naval surgeon around 1750. and he was considered to be the first person to ever run a medical trial, and he established the importance of vitamin C in treating sailors for scurvy. So what are the PPI issues for today? I see at a very high level that there are 3 levels that a patient can be involved with the trial participants. You actually participate in a drug trial. This could be because you're suffering from a disease, or it could be, as more recently in COVID, where you take either vaccination or a placebo. Medium, there are a large number of people who participate in big data studies, such as Our Future Health. And low, where simply you're providing your anonymized data is used for research. And I'm really stating what is clearly my own personal viewpoint and doesn't represent the viewpoint of every patient in the UK, while active participation requires explicit patient consent, just use of data doesn't. And I guess I don't agree with the idea of an opt-out. Within the UK, there are many precedents of using patients' anonymized data. So now that we've got a definition of PPIE, I'll state what I think are, for me, the PPI issues specific to the use of imaging data. Confidentiality, patient consent, and data ownership. Routine data is obtained during imaging carried out both for clinical reasons and when part of the research program. Now, clearly, when a patient is part of a research program, then they'll give their consent to being part of that research program. So the PPIE viewpoint needs to be wider than just patients who volunteer to take part in the trial. So what's the question a patient will ask, or might ask? The big issue of confidentiality is, will the degree of data anonymization be sufficient so that nobody can identify me and my comorbidities from image data? And people who might want my data may range from curious to those having a commercial objective. And some examples of these, what are called hostile actors, are journalists, insurance companies, or even simply pupils trying to find out about their teachers. Now, to state the obvious, the larger the supporting the data set, the higher the risk of reverse engineering. And the commissioning clinician always provides the imaging team with certain minimal background of such as patient age and key symptoms. Now, coming on to public confidence, and public confidence in data anonymization is essential. People are spoken to and about this and understand the concept of anonymized data, and they generally are for taking part in its use. Now, in this slide, I tried to make a loose analogy of how the public accepts the certain software processes which they don't understand. Now, the 2 examples I give are, 1, password hashing. Password hashing is a non-reversible operation on passwords. It protects the password and associated personal data. Its integrity is generally accepted even though the process by the average member of the public isn't understood. And I liken this to the process of data anonymization. Whilst I understand about password hashing, I know nothing about data anonymization, and yet I do accept it if it's carried out according to the relevant standards. So Other speakers today have already talked about patient consent. I've already given my personal view that patient consent is not required for the use of imaging data, but it's worth looking at what some other programs do. Our Future Health requires patient consent, and it allows the patient to withdraw consent, but this is something that Andrea referred to in our earlier chat. Although it allows the patient to withdraw consent, information to that point has to be retained. And if you develop any software tool, you need to be able to possibly run it again 5 years in the future. So it needs to be archived, which I think implies that you need to have all the data underpinning that tool there. Other speakers have talked about the legal position on this. I had a look at what the Information Commissioner's Office has to say, and my interpretation of the GDPR guidance is that developing AI algorithms classes research processing and does not require specific patient consent. And there's certain provisos to this, safeguards, including adherence to relevant frameworks. In other words, they're saying you've got to make sure that you do proper minimization, you've got to have auditing, and and the ICO is currently working on specific guidance for anonymization. Moving on, who owns the data? Data from NHS procedures should be owned by the NHS. Anonymized data should be available for both academic and commercial diagnostic users. I think it's useful to make anonymized data generally available so that independent researchers can either develop their own algorithms or develop or validate algorithms. And in terms of use of the data for reasons other than research, I would say no. And looking at some other programs, once again, Our Future Health, it makes an offer to potential volunteers. We will never sell your data to advertisers or insurance companies. Now, it's quite important to earn the public's trust in AI tools. So what's the first element? Well, the test data must match the actual target population rather than be a random subset of the same data pool as the training data. I was recently at a presentation on AI, which included the fact that some facial recognition systems failed on darker skin colors, and simply because they hadn't been properly analyzed. And I thought that this particular Nature article is a useful reference. And there is actually a group which tries to promote this. Now, the use of imaging data is a subset of the wider issue of managing health data records, and NHS is conducting survey of public attitudes. My big concern in all of this is I was amazed at the number of independent NHS and NIHR groups who look into this, public lobbying groups, and I think that it might be a useful exercise if somebody wanted to give an undergraduate project to look into the number of different groups looking into this and their overlap and what their agendas are. And so finally, just what's happening today, today being November 2023 when I wrote this. There was a release, it was reported in the Observer. I stand corrected if somebody knows better. there was a release by the UK Biobank of research data to insurance companies, which is not in accordance with its pledges, and the controversial award of the Federated Data Platform to Palantir. And to give my viewpoint, insurance companies do require data to work out risk. I think acceptable data for a life insurance company would be factors such as your gender, location, and lifestyle. The tailoring medical risk to individuals' health history is grey area. High-level data such as have you had lung cancer, I think is a fair question, but I would strongly disagree with risk being based on personal data such as DNA profile. Risk, the use of imaging data, don't know. I do think it's a grey area. And also think it's not okay to make promises and then not comply with this. Doing so lowers confidence for the UK public in other health research programs. Thank you.